Hi, my name is Dr. Aaron Rosen, and I am a site director at a hospital in California. And I would like to tell you about an interesting case that we had. So, we had a patient who was admitted by one of the private physicians at about 22 weeks with cervical insufficiency. Following her admission, her private doctor left town. She was left in the care of OBHG, as the hospitalist said, that covered the hospital. We had a lot of discussions with her about her case. She was 22 weeks with cervical insufficiency and was found to have bulging membranes into the vagina. She was seen by us and by MFM, and it was determined that it was not a safe case to place a cervical cerclage. And the patient was very unsure about how she wanted to proceed. We had a lot of discussions about the morbidity associated with. And prior to the patient making any sort of decisions, she basically wanted no interventions and to be left alone to remain as pregnant as she could for as long as she could. Unfortunately, throughout her admission, the cervical insufficiency worsened. And as she approached the 23rd week of pregnancy, it wasn't just bulging membranes into the vagina, but she was found to be in breech presentation with both legs in the vagina as well. And miraculously, she managed to stay pregnant until she reached the 23-week mark, in which case we really started to have more detailed conversations about what we were going to do for her and for the baby and what decisions that she needed to make. And the patient kept flip-flopping in terms of she wanted a vaginal delivery, but then she wanted everything done for the baby to make the baby as safe as possible. If she wanted everything to be done, the safest route of delivery was a cesarean section, because a classical C-section for a 23-week baby is the safest route of delivery. Unfortunately, during one of these conversations that I was having with her was when she decided to get into a more active preterm labor picture, and her contractions increased and her pain increased, and we were worried that she was actually going into labor. And at this point, I had one final conversation with her about what this meant for her and for the baby, and she agreed to a cesarean section. And thankfully, because I was there and the baby was already a third of the way into the vagina, we were able to rush her back for a C-section, excuse me. And we were able to deliver the baby without any complications via classical cesarean section. And the mom did really well. And I'm happy to say that after about 3 months, this baby, being the little engine that could, just kept chugging along, and he's done really well in the NICU, and he's just about ready to go home. So I think the benefit in this case, in particularly having an in-house hospitalist laborist program, is that we're available when these cases turn in a direction that can be really dangerous. These kinds of things tend to happen very quickly. And when they do, we're already in the hospital, or in this case, I was already talking to the patient when this happened. So we were able to get this patient evaluated, determine the appropriate course of management, and get her C-section done very quickly, within a few minutes, rather than waiting 30 plus minutes for someone to come in from out of the hospital.